Good morning, ladies and gentlemen. The topic of today's lecture is ulceration resulting from disorders of veins and arteries. I am Brigadier Retired Asher Ahmed Mashood, and you can follow me on my Instagram, email, or through my WhatsApp number. Leg and foot ulcers represent a serious burden of disease. The pain it causes, the disturbance of sleep that occurs due to the ulcers contributes to the poor quality of life. There are four major categories of leg ulcers. The first and the most commonest are the venous leg ulcers. Then there are mixed venous and arterial leg ulcers. Then pure arterial ulcers. And number four are the hypertensive ischemic leg ulcers. So all these four categories cover 80% of the underlying cause of leg and foot ulcers. The CEAP or KEEP classification system is used to assess venous pathology, pathophysiology, and chronic venous insufficiency. I have mentioned this classification in my previous lecture on diseases of veins and arteries. The fundamental of CEAP classification is the C stands for the clinical class, which is based on the objective signs. Then E represents etiology. A represents the anatomical distribution, that is in superficial, deep, or perforating veins. And P is the pathophysiology, whether the ulcers are due to whether the pathology is due to the reflux or obstruction in the venous system. First, we are going to discuss the venous leg ulcers. The venous leg ulcers are the chronic skin ulcers at the gaiter area. The gaiter area is the area which is between the knee and ankle, that results from chronic peripheral venous hypertension. So chronic peripheral venous hypertension is the main cause of chronic venous ulcers. They represent the most advanced grade of chronic venous insufficiency. So passing through different stages of venous insufficiency, once the leg ulcers develop, then this represent the most advanced grade of chronic venous insufficiency. The chronic venous insufficiency results from chronic peripheral venous hypertension that is caused either by the venous reflux or obstruction. And it may be because of neuromusculoskeletal dysfunction of the leg. The reversible morphological changes associated with venous ulcers are stasis eczema, lipodermatosclerosis, and atrophy blanchi. So, if these changes are present in the leg, in addition to an ulcer, then it is almost sure that the ulcer is due to venous insufficiency. As you treat the venous ulcers, these and improve the venous circulation, the other associated skin changes also improve. Incidence and prevalence. The lifetime incidence of leg ulcer in a person is 1%, is around 1%, with a point prevalence of 0.1%. Venous leg ulcer primarily affect individuals above 65 years of age, and they are equally distributed in women and men. But since women live more, there are more chances of venous leg ulcers in aged women. Leg ulcers occur in any country and any population. And venous leg ulcers are seen more commonly in people who are with standing occupations and those who are obese and Western lifestyles with minimal physical exertion predisposed to venous leg ulcers. There are several disorders which are associated with venous leg ulcers like venous thromboembolism, superficial venous thrombophlebitis, varicose vein, chronic venous insufficiency as shown by the signs mentioned before, stasis dermatitis, lipodermatosclerosis, like these signs, acroangiodermatitis, then obesity, ankle joint ankylosis, rheumatoid arthritis, and neuromuscular disease that affect the venous calf pump may be a cause of venous leg ulcer. Pathophysiology: gravitation, upright walk, and dysfunctional venous ejection during the leg motion, dysfunctional venous drainage due to obstruction, for example, chronic occlusion, obesity, or pregnancy, are all the prerequisites to development of chronic venous insufficiency and venous leg ulcer. The perforating vein insufficiency is a rare cause, and so is the congenital valvular aplasias. All forms of neuromuscular diseases or ankle and knee joint dysfunction also induce chronic venous insufficiency and venous leg ulcers. Obesity is an important contribution, as obesity raises the intra-abdominal pressure that impedes the venous drainage. Venous hypertension induces changes that remain reversible in early stages, such as stasis dermatitis, and becomes irreversible in later stages like lipodermatosclerosis and atrophy blanchi. Chronic and recurrent protein-rich edema and aseptic inflammation induce fibrosis and tissue hypoxia that is a cause of venous leg ulcer. The main pathology of venous leg ulcer is a sclerosing panniculitis with non-specific skin ulceration. So how does it start? The epidermis is acanthotic, thick epidermis. The subpapillary veins are elongated. They are elongated and thickened, and there is hemosiderin deposition, and fibrotic dermis shows fibrosis as seen here. The fascia is thickened and leg muscles show fatty degeneration. The ulcer itself is non-specific with granulation tissue and mixed inflammatory infiltrate. Clinical features: the chronic skin ulceration due to chronic venous insufficiency are commonly seen in area between the knee and ankle, along with the trophic skin changes like stasis dermatitis, here the stasis dermatitis along with the ulcers, pigmentation, thickening or induration, and later on lipodermatosclerosis. The clinical variants include the semi-circumferential or circumferential ulcers and ulcers that develop at the lateral dorsum of the foot and dorsum of the toes, because the usual site is the medial side, which is the greater saphenous vein area. Complications and comorbidity. This is called chronic pain, impaired quality of life, local wound infection, systemic infection and sepsis, and if the wound is very dirty, then infestation with maggots, and if a very chronic, non-treated ulcer, then it can lead to secondary squamous cell carcinoma and secondary lymphedema. Disease course and prognosis. Venous leg ulcers are chronic and recurrent unless patients receive an accurate diagnostic assessment and treatment. Investigation and assessment. This is a very important part of this topic. The vascular investigations include assessment of peripheral arterial disease, calculation of ankle brachial pressure, ABPI, then assessment of venous flow by continuous wave Doppler ultrasound, and sometimes venography is also quite useful. Then after the vascular investigation, the wound should be documented, measure the wound size and its morphological qualities, and should be documented at every visit daily if the patient is admitted. Then electronic photographic documentation is also important. Everybody is keeping a mobile phone with him, so a picture should be taken periodically of the ulcers. Microbiology is important because there is always a chance of secondary bacterial infection. So in presence of clinical signs of critical colonization or bacterial cellulitis or sepsis, then the specific antibiotics may be prescribed. Sometimes wound histology is important when there is a suspicion of vasculitis, pyoderma gangrenosum, hypertensive ischemic leg ulcers, malignant skin ulcer, or refractory chronic leg ulcers showing no trend to heal even after 3 months of proper treatment. Assessment of malnutrition is also important because malnutrition hampers the healing of ulcer. So measure the total proteins, albumin, and lymphocyte count to document about the malnutrition. Pain assessment is important because we may have to make the patient comfortable, and patient pain assessment should be made regularly, that is 4 weekly intervals with a reproducible method like a visual analog scale. Then assessment of quality of life should be done initially and after 4 weeks with a standardized QOL questionnaire. Treatment option of venous leg ulcer. The conservative management include the compression therapy, which is the inelastic or elastic intermittent pneumatic compression. This compression therapy is the standard care with proven benefit. The benefit of intermittent pneumatic therapy is less clear. And this is associated with decreased rate of ulcer recurrence as well. So if once the ulcer is treated, the patient should be advised to regularly wear these compression garments. Leg elevation. This is also one of the standard care, and when used along with compression therapy to minimize the edema. And it is recommended that 30 minutes of leg elevation is done 3 times a day. Dressing. No one type of dressing is superior. So from the normal antiseptic dressing to Duoderm and other fancy dressings can all be used. Mechanical treatment include topical, negative pressure or vacuum-assisted closure. There is no robust evidence suggesting its effectiveness in venous leg ulcers. There are a long list of medications. The first is the pentoxifylline or Trantil. It is effective when used with compression therapy and can be used as a monotherapy. Aspirin is effective when used with compression therapy. Dose is 300 milligram once a day. Iloprost. Intravenous administration of iloprost, it is not available in USA, but can be found here. It is beneficial, but data is insufficient to recommend its use, and it is, of course, of high cost. Oral zinc is used to treat the chronic ulcers, but has no proven benefits. Antibiotics and antiseptics. Oral antibiotic is used in case of secondary wound infection or cellulitis, but routine use of systemic antibiotics in an ulcer that seems to be non-infectious has no healing benefit. There is a benefit of adding topical antiseptic iodine or pyodine or antiseptic or topical antibiotic ointments. Hyperbaric oxygen therapy has no proven benefit. Then surgical management, debridement. Debridement is usually not required, but more studies are needed to establish benefit. Human skin grafting, more studies again are needed. Artificial skin, sometimes it's beneficial with compression therapy, there is concern about infection transmission. Then, in case of venous insufficiency, surgery must be done to treat the venous insufficiency, and this will cure the severe and refractory cases and will decrease the rate of ulcer recurrence. Now we are going to discuss another category of leg ulcers, which are called as the mixed leg ulcers. We call it as mixed leg ulcers because these ulcers are venous leg ulcers along with the peripheral arterial disease. And these ulcers, since they are because of veins and arteries, they are harder to heal as compared to a pure venous leg ulcer. Approximately 20% of the leg ulcers are mixed leg ulcers. Mixed leg ulcers occur in individuals over 65 years, and it is rare in young age since peripheral arterial disease occur mainly in population above 50 years. Mixed leg ulcers occur equally in men and women, and Western lifestyle increase the incidence of mixed leg ulcers and chronic venous insufficiency, as already mentioned. Bimalleolar, both medial and lateral malleoli ulcer location is more common in mixed leg ulcer. Most patients with mixed leg ulcers are in Fontaine grade 2 peripheral arterial disease, but do not meet the criteria of chronic limb ischemia. The mixed leg ulcer patients with more advanced peripheral arterial disease do not tolerate the compression therapy, and hence the treatment becomes little difficult. The management primarily focuses on improving the arterial flow, mostly by use of balloon catheter angioplasty, by percutaneous transluminal angioplasty transforming the mixed leg ulcer into a venous leg ulcer. So first, if an ulcer has both the arterial and venous component, then it is imperative to treat the arterial component first and then converting it into a pure venous leg ulcer, because then the treatment of venous leg ulcer is more easier. As soon as the arterial flow is restored, the management follows the algorithm of venous leg ulcer, as mentioned before. The disorders which are associated with mixed leg ulcers include almost the same disorders which were present in the venous leg ulcers, like venous thromboembolism, superficial venous thrombophlebitis, varicose vein, chronic venous insufficiency, stasis dermatitis, lipodermatosclerosis, and acrodermatitis. In addition, the other factors which are contributory, which are mainly contributing towards the arterial leg ulcers, are obesity, smoking, diabetes, hyperlipidemia, hypertension, coronary heart disease, and stroke. The clinical features. These mixed leg ulcers are usually have a family history of chronic venous insufficiency and venous leg ulcer. Other common features are obesity and standing occupation, neuromuscular disease, and joint disease. Mixed leg ulcers cannot be clinically distinguished from venous leg ulcers, although bimalleolar distribution is more towards a mixed leg ulcer rather than a pure venous ulcer, because pure venous ulcers are usually located on the medial side. These ulcers may be semicircumferential or circumferential in extensive cases. Complication and comorbidities are chronic pain and impairment of quality of life, local wound infection, systemic infection, sepsis and infestation with maggots, secondary SCC, secondary lymphedema, extensive tissue necrosis requiring major surgery or maybe amputation, and there is a high risk of recurrence in mixed leg ulcers, that is 50% risk in 1 year. The recommended investigations are same as mentioned before in the section of venous leg ulcers. This is the management algorithm of venous leg ulcer. First of all, the wound documentation by photometry at every visit, then pain assessment at every visit, and measurement of quality of life assessment. The vascular assessment of an ulcer by arterial as well as venous examination, and the assessment depends upon the arterial examination. In case of mild peripheral arterial disease, that is the ankle pressure of more than 100 millimeter of mercury, conservative treatment and compression therapy is the treatment. In case of moderate peripheral arterial disease with ankle pressure less than 100 mm of mercury, then conservative treatment is resorted with reduced compression. Then in case of severe peripheral arterial disease with pressure less than 80 mm of mercury systolic, then the patient should be evaluated for percutaneous transluminal angioplasty. The compression therapy according to venous leg ulcers, edema refractory to appropriate compression. If the edema is refractory to appropriate compression, add intermittent pneumatic compression. If there is, if ulcers tend to heal, then compression treatment is continued. If it is not healing, then evaluate again for PTA or bypass, and with no trend to healing, then again evaluate for re-PTA and also evaluate for iloprost infusion. Now we have come to the third kind of ulcers, which are the arterial leg ulcers. The arterial leg ulcers are primarily caused by skin ischemia due to advanced peripheral arterial disease. They occur spontaneously or after minor trauma to area of ischemic skin. The lifetime incidence of leg ulcer is 1%, while arterial leg ulcer and hypertensive leg ulcers is approximately 10% of all the leg ulcers. Arterial leg ulcers generally occur in individuals above 60 years of age and are equally distributed in women and men. And again, since women live longer, so there are more chances of having arterial leg ulcers in old women. Western lifestyles with little exertion increases the risk of arterial leg ulcers as it increases the risk of venous leg ulcers. The associated diseases are obesity, smoking, diabetes, hyperlipidemia, hypertension, coronary artery disease, and stroke. These factors were already mentioned in mixed leg ulcers. Pathophysiology. Occlusion of one or several branches of atherosclerotic calf artery may directly or irreversibly shut down the skin circulation of a well-circumscribed area. Then the affected skin becomes cyanotic and then necrotic. And this whole process is accompanied by severe ischemic pain. It remains to be shown if lateral or pretibial skin circulation is less abundant and collateralized than the medial and dorsal aspect of leg, which would explain the proneness of these locations. So this means that the more predisposing side of arterial leg ulcer is the lateral malleolus and dorsum of the foot rather than medial foot, although it is not sure if these areas are deficient in collateral circulation as compared to the medial side. Pathology. The histology of arterial leg ulcer is non-specific. It shows tissue necrosis, and in case of critical colonization of bacteria, dense inflammatory infiltrate with polymorphonuclear leukocytes. The clinical features. Initially, they present as a black scar, as you can see in the picture, or poorly granulating skin ulcer with the necrotic black wound border. So granulation tissue is poor in arterial leg ulcers. Then the ulcer is well demarcated, sharp, with steep wound border, and ulcer surface tend to progress rapidly. Wound pain is strong and excruciating, and there is a common source of temporary relief of the pain when the foot is dangling over the edge of the bed, allowing the gravity to aid the blood flow to ulcer region. So if you dangle the leg from the bed, ulcer pain reduces. The small arterial leg ulcers are rounded in shape and have a punched out appearance, while larger leg ulcers are polycyclic and figurative, as you can see in the pictures. Arterial ulcers at the dorsum of foot usually occur in very advanced peripheral arterial disease. In addition to the ulcer, the limb will feel cold to touch and peripheral pulses will be weak in comparison to the other side. So these are the must examination tips for the arterial leg ulcers. Skin and nail show trophic changes, which include the hair loss and nail dystrophy, and the skin appear thin, dry, and taut. The base color of extremity may turn red when dangled or dependent and pale when elevated. Addition signs of leg ulcer is delayed capillary return in affected extremities. Then classification of severity is very important, and it is done by a clinical examination, which is called as the ankle brachial pressure index. This can be done by normal sphygmometer, BP apparatus, or by Doppler pressure index. By measuring the blood pressure by a normal BP apparatus, we measure the blood pressure at the ankle as well as at the brachial artery. If now we keep the pressure of the ankle in the numerator and pressure of the brachial artery at the denominator. If the ratio is 1, that is both pressures are equal, then it is normal. If the ratio is 0.71 to 0.9, it is the mild peripheral vascular disease. If the pressure is between 0.41 to 0.7 then it is moderate peripheral vascular disease. If the ratio is less than 0.41, it is severe vascular disease. And if the ratio is 0.2, then it is a very severe limb ischemia which is leading to gangrene. Further classification of severity is done on the basis of Fontaine grade. The Fontaine grade 2 is the peripheral arterial disease associated with intermittent claudication. And if the pain is without movement, then it is Fontaine grade 3. And toe or foot necrosis or gangrene is Fontaine grade 4. The higher grade, that is 3 and 4, of peripheral arterial disease commonly fulfill the criteria of chronic limb ischemia, which is defined as the systolic pressure of less than 50 millimeter of mercury at the ankle, less than 30 millimeter of mercury at the toe, and transcutaneous oxygen pressure of less than 30 millimeter of mercury. The arterial leg ulcers usually do not fit in the Fontaine classification, but approximately 90% correspond to the Fontaine grade 2, but it is not necessary to have the intermittent claudication along with the leg ulcers. But this question must always be asked in patients suspected to have an arterial leg ulcer. The complications and comorbidities. The chronic pain and impairment of quality of life is the most important symptom. Local wound infection, secondary wound infection, sepsis, and infestation with maggots, as common in all the ulcers. Extensive tissue necrosis may require surgery or amputation. Disease course, prognosis, and management. The recommended investigations are same as mentioned in the section of venous leg ulcers. If peripheral arterial disease is amenable to PTA, that is balloon catheter angioplasty, prognosis is favorable. Successful peripheral arterial disease treatment not only alleviates pain but also heals the ulcer. But not all arterial leg ulcers heal spontaneously after revascularization. The major benefit from early skin graft is to speed up the wound healing and terminate wound pain. The recurrence of arterial leg ulcer is exceptional, unlike venous leg ulcers and mixed leg ulcers. In patients who are not amenable to revascularization, iloprost perfusion can add some benefit, as it improves the microcirculation. Wounds should be kept debride, and occlusive wound dressings are contraindicated. Course of antibiotic treatment may be required to treat infection and reduce peri-wound edema and improve the chances of healing. Split skin graft should be tried even under suboptimal local conditions like little granulation tissue. So this is how the arterial leg ulcers should be managed. Wound documentation is must by photograph at every visit, pain assessment, and QOL assessment. Then vascular assessment is important, and conservative treatment in case of normal ankle pressure, and treat the cardiovascular risk factor and debridement. And in case of refractory arterial leg ulcers, revascularization should be attempted, antibiotic is needed, and skin graft for large ulcers. In critical limb ischemia, amputation may be done if there is no other way to treat it. Then once the ulcer is showing healing, then sustain analgesic treatment, debridement, antibiotic course, repeated application of skin equivalent or autologous skin graft, protection of the pressure points, skin care, and nail care. The last of the ulcer to be discussed today are the hypertensive ischemic leg ulcers. They represent the skin infarction due to ischemic subcutaneous arteriosclerosis occurring in patients with long-standing hypertension. They are defined by Martorell in 1945. Hypertensive ischemic leg ulcers represent a form of skin infarction due to occlusive subcutaneous arteriosclerosis. Approximately 70% of histological slides of such cases reveal thickened arterioles displaying medial calcinosis. The wound location is also characteristic, and more than 90% of patients, the scar or wound is located at the laterodorsal aspect of the leg and over the Achilles tendon. Patients have hypertension, and 60% have type 2 diabetes. The arterial leg ulcers and hypertensive ischemic leg ulcers together account for 10% of all leg ulcers. Long-standing hypertension and diabetes mainly affect individuals of 50 years and above. Therefore, hypertensive ischemic leg ulcers occur in patients over 60. Equally distributed in men and women, and Western lifestyles increases the risk. Associated diseases are similar to the associated diseases of arterial leg ulcers. Pathophysiology. This is an ischemic skin infarction caused by subcutaneous arteriosclerosis as seen in the pictures. It is a non-life-threatening but highly symptomatic late complication of hypertension. Both clinical and histologically, hypertensive leg ulcers cannot be distinguished from distal calciphylaxis. This suggests a common pathophysiology based on shared risk factors like hypertension and diabetes. Clinical features. The patient usually presents with single or multiple scars and skin ulcers at the lateral dorsal aspect of leg and over the Achilles tendon. Wound border is livid, as you can see, violaceous or black, and ulcer occur within areas of livedo reticularis. Initially, there is a rapid progression accompanied by excruciating pain. Then necrosis accompanies all skin level and extend down to the fascia. The arteriosclerotic skin ulcers occur in distal pattern, which is the arterial hypertensive ischemic leg ulcers as shown before. And it is also seen in proximal pattern involving the medial thigh, groin, abdomen, upper arm, and breast, which is referred to as calciphylaxis, as you can see in the picture in which the ulcer is shown on the thigh. The clinical variant are the medial or pretibial location and skin necrosis over the Achilles tendon as the sole manifestation. The differential diagnoses are pyoderma gangrenosum and vasculitic leg ulcers. Complications include chronic pain, impaired quality of life, local wound or systemic infection and sepsis, extensive tissue necrosis that require major surgery or an exceptionally amputation. Disease course and prognosis. Prognosis is good even though hypertensive ischemic leg ulcer represents severe disease in aged patients. Half of the patients do not require not only one but several skin grafts to completely heal the wound. Even if a skin graft do not take up, pain is almost immediately alleviated. Investigation. Recommended investigations correspond to the investigations mentioned in arterial leg ulcers and venous leg ulcers. And management contain the necrosectomy, that is removal of necrosed area, local negative pressure wound treatment, and eventually skin graft. So this is the algorithm for hypertensive ischemic leg ulcers. It's important to do the arterial examination and venous examination, do a wound biopsy to exclude other causes of ulcers like pyoderma gangrenosum and vasculitis, treat hypertension, which is the most important part, and then treat the type 2 diabetes, which is present in almost 60% of the cases. If patient is receiving vitamin K antagonist, it should be replaced by other anticoagulants, and then treat pain. If there is no sign of clinical infection, we don't need any antibiotics, and we go directly to the wound care. If there is critical colonization, then microbiology is done and debridement should be done. In case of cellulitis, then systemic antibiotic therapy is must. In case of normal arterial examination, exclude the subcutaneous arteriosclerosis. Peripheral arterial disease is evaluated by duplex sonography, angiography, and if required, perform a balloon catheter angioplasty. If there is a small ulcers less than 5 centimeter, it will heal by debridement, by conservative wound treatment, and sometimes it requires skin equivalent dressing. A large ulcer more than 5 centimeter or in case of refractory hypertensive ischemic leg ulcers, we proceed by removing the necrotic tissue and giving systemic antibiotic, then local negative pressure wound treatment and autologous skin graft. For extensive or life-threatening skin necrosis, intravenous sodium thiosulfate. For continued healing, sustained analgesic treatment, debridement, non-occlusive dressings, antibiotic course as required, and repeated application of a skin equivalent or autologous skin graft. So this brings to end of this talk. I hope this talk was beneficial to you because leg ulcer is one of the important cases which comes in the exam and comes in your OPD. In both cases, you need a detailed examination to give the better results and to cure and treat the ulcers in a timely fashion. I thank you all for a very patient listening.